Blood transfusion. There are no firm criteria for initiating red cell transfusion. The decision to provide a blood transfusion should be based on both clinical and hematological assessment. While the blood transfusion is almost always required when the hemoglobin is less than 60 grams per liter and rarely required when the hemoglobin is more than 100 grams per liter, patients with acute hemorrhage can have normal hemoglobin, and clinical evaluation in this situation is therefore extremely important. Selection of red cell units for transfusion. Major obstetric hemorrhage protocols must include the provision of emergency blood with immediate issue of Group O, rhesus D, or RHD negative and K negative units with a switch to group-specific blood as soon as feasible. Pregnant women and women of childbearing age who are RHD negative must only receive RHD negative blood to avoid the risk of alloimmunization. Previous blood transfusion is an important cause of alloimmunization with antibodies other than anti-D, in particular anti-K, causing severe hemolytic disease of the fetus and newborn. Accordingly, unless a woman is known to be K positive, only K negative blood should be used for transfusion in women of childbearing age. The aim of antibody screening is to determine the presence of red cell antibodies of likely clinical significance. In addition to the risk of hemolytic disease of the fetus and newborn, these red cell antibodies may have implications for the selection of blood for transfusion in the mother owing to the risk of hemolytic transfusion reactions, and the laboratory should select red cell units negative for the relevant antigen for cross-matching. If clinically significant red cell antibodies are present, close liaison with the transfusion laboratory is essential to avoid delay in transfusion in life-threatening hemorrhage. All delivery units, especially small units without a blood bank on site, should maintain a supply of Group O RHD negative blood, as this might offer the only means of restoring oxygen carrying capacity within an acceptable timescale. The minimum number of units of Group O RHD negative, K negative blood to be maintained on site should be agreed within local protocols and should reflect the likely period of delay in the arrival of further supplies should an emergency arise. Small delivery units, remote from the nearest blood bank, will require a larger minimum supply than those a short distance from a blood bank. Cross-matching versus electronic issue of blood. The majority of laboratories in the UK now use automated testing for blood grouping and antibody testing with advanced information technology systems for documentation and reporting of results. The hospital transfusion laboratory can readily provide red cells that are ABO and RHD compatible using electronic issue with no cross-matching needed, provided that the patient does not have any antibodies and there are robust automated systems in place for antibody testing and identification of the patient. In this setting, since blood can be readily issued, there is no need to reserve units for individual cases. Where electronic issue is not available, a locally agreed maximum surgical blood ordering schedule should be used to decide how many red cell units should be reserved and available for particular cases based on the obstetric diagnosis. In unforeseen hemorrhage, Group O, RHD negative, and K negative units must be immediately available for emergency use with a switch to group-specific blood as soon as feasible. Cytomegalovirus or CMV status. In elective transfusion in the antenatal period, CMV, seronegative products, should be used to avoid transmission of CMV to the fetus although the UK policy of universal leukocyte depletion substantially reduces the risk of CMV transmission. In an emergency such as postpartum hemorrhage, standard leukocyte-depleted components should be given to avoid delay, and CMV-negative blood or platelets are not needed for transfusion during delivery or in the postpartum period. Intraoperative cell salvage. Intraoperative cell salvage should be considered for emergency use in postpartum hemorrhage associated with cesarean section and with vaginal delivery. Intraoperative cell salvage, the process whereby blood shed during an operation is collected, filtered, and washed to produce autologous red blood cells, or RBCs, for transfusion to the patient, is commonly being used in cardiac, orthopedic, and vascular surgery with a relative reduction of blood transfusion of 38% and an absolute risk reduction of 21%. Cell salvage does not appear to impact adversely on clinical outcomes. Several bodies have endorsed cell salvage in obstetric practice, including the National Institute for Health and Care Excellence, the Center for Maternal and Child Inquiries, and the Association of Anesthetists of Great Britain and Ireland. It has been proposed that cell salvage should be considered for emergency use in postpartum hemorrhage associated with both cesarean section and vaginal delivery. Blood components. Methods to assess hemostatic impairment during postpartum hemorrhage include clinical observation, laboratory-based tests such as prothrombin time, activated partial thromboplastin time, close fibrinogen and platelet count, and point-of-care testing. Coagulopathies may evolve rapidly, and repeated testing, such as every 30 minutes, during continued bleeding and observation of trends, are more useful than single measurements. Close fibrinogen should always be measured as part of the routine coagulation screen because it falls early and may be reduced to a clinically significant level despite a normal prothrombin time or activated partial thromboplastin time. Platelet number should be measured as part of the full blood count. Transfusion of fresh frozen plasma. The drawbacks of early fresh frozen plasma are that the majority of women with postpartum hemorrhage will have normal coagulation at the time of administration, and that it is associated with an increased risk of transfusion-associated circulatory overload, or TACO, and transfusion-related acute lung injury. If no hemostatic tests are available, early FFP should be considered for conditions with a suspected coagulopathy, such as placental abruption or amniotic fluid embolism, or where detection of postpartum hemorrhage has been delayed. If the postpartum hemorrhage has stopped, no FFP is required. No fresh frozen plasma is required. If hemorrhage is ongoing and the last prothrombin time and activated partial thromboplastin time results are available and are prolonged, 12 to 15 milliliters per kilogram of fresh frozen plasma should be requested and infused with the aim of maintaining the PT-APTT at less than 1.5 times normal. If the PT and APTT is greater than 1.5 times normal, a larger volume of fresh frozen plasma is likely to be required to correct these parameters, and this may be associated with an increased risk of transfusion-associated circulatory overload. If the prothrombin time and activated partial thromboplastin time are normal, then no fresh frozen plasma is required, although repeated testing should be performed if bleeding persists. If the results of hemostatic tests are not available and hemorrhage is continuing, then after 4 units of RBCs have been transfused, FFP should be infused at a dose of 12 to 15 milliliters per kilogram and 6 to 4 RBC to fresh frozen plasma transfusion maintained until tests of hemostasis are available. Such empirical use of FFP is in line with published guidance. Fresh frozen plasma transfusion earlier than this could be considered for placental abruption or amniotic fluid embolism because these situations are associated with early coagulopathy or if diagnosis of postpartum hemorrhage has been delayed. Fibrinogen. A plasma fibrinogen level of greater than 2 grams per liter should be maintained during ongoing postpartum hemorrhage. Cryoprecipitate should be used for fibrinogen replacement. It is expected that 2 pulls of cryoprecipitate would increase the fibrinogen level by about 1 grams per liter. Increasing the fibrinogen level by 1 grams per liter requires about 60 milligrams per kilogram fibrinogen concentrate. Transfusion of platelets. During postpartum hemorrhage, platelets should be transfused when the platelet count is less than 75 multiplied by 10 to the 9 power per liter based on laboratory monitoring. To maintain a level greater than 50 multiplied by 10 to the 9 power per liter during ongoing postpartum hemorrhage. It is expected that 2 pulls of cryoprecipitate would increase the fibrinogen level by about 1 gram per liter. Increasing the fibrinogen level by 1 gram per liter requires about 60 milligrams per kilograms fibrinogen concentrate. Is there a role for recombinant factor 6A therapy? The routine use of recombinant factor 6A is not recommended in the management of major postpartum hemorrhage unless as part of a clinical trial. It reduces blood loss through enhancement of tissue factor-dependent coagulation. Its effectiveness is markedly diminished by hypothermia, acidosis, and low platelets, so effective resuscitation towards normal physiology is a prerequisite of its use. The use of recombinant factor 6A may be considered as a treatment for life-threatening postpartum hemorrhage but should not delay or be considered a substitute for a life-saving procedure such as embolization or surgery or transfer to a referral center. Monitoring and investigation in major postpartum hemorrhage. What investigation should be performed and how should women be monitored? Full protocol for monitoring and investigation in major postpartum hemorrhage are a blood loss greater than 1,000 milliliters and ongoing hemorrhage or clinical shock. Immediate venipuncture, 20 milliliters, 4, cross-match 4 units minimum, full blood count, coagulation screen, including fibrinogen, renal and liver function for baseline. Monitor temperature every 15 minutes, continuous pulse, blood pressure recording and respiratory rate using oximeter, electrocardiogram, and automated blood pressure recording, Foley catheter to monitor urine output, 2 peripheral cannula, 14 gauge, consider arterial line monitoring, once appropriately experienced staff available for insertion, consider transfer to intensive therapy unit once the bleeding is controlled or monitoring at high dependency unit on delivery suite if appropriate, recording of parameters on a modified early obstetric warning score or MEOWS chart, acting and escalating promptly when abnormal scores from a modified early obstetric warning score chart are observed, and documentation of fluid balance, blood products, and procedures. Continuous physiological monitoring is necessary, and the recording of parameters over time on a flowchart that will give the reader good visual cues on the clinical progress of the patient. The need to continually re-evaluate the woman's physiological condition, even when bleeding appears to have stopped, is essential to recognize continuing bleeding. Central venous and direct arterial pressure monitoring should be used when the cardiovascular system is compromised by hemorrhage or disease. Central venous pressure monitoring requires early involvement of a senior skilled anesthetist who will usually take responsibility for this aspect of management. The use of ultrasound is more likely to make the procedure safer, as this procedure carries significant morbidity and mortality. Once bleeding is under control, transfer to an intensive care or high dependency unit on delivery suite should be considered, depending on the severity of the blood loss. It is also important that once the bleeding is arrested and any coagulopathy is corrected, chemical thromboprophylaxis is administered, as there is a high risk of thrombosis. Alternatively, anti-embolism stockings, foot impulse devices, or intermittent pneumatic compression devices can be used if chemical thromboprophylaxis is contraindicated, for example, in cases of thrombocytopenia.